Good evening, everyone. I'm doing this Facebook Live for the first time, so I'm not sure whether everything is going well in terms of my audio, the PPT, and the streaming. If someone give a feedback by a message, if everything is fine, I can start my presentation. Just give me a message. If I'm audible, my slide is clear, and the streaming is well, just give me a thumbs up so that we will start soon. Once few people also joins, we will start our presentation. Okay, so I think I'm audible. Just give me a thumbs up, someone please, so that I'll be knowing everything is fine. Okay then, so we will start. I'm giving a very good evening to all. I hope all are safe and good in your respective places. I will start with a very brief introduction about me. I am Dr. Jojo Kotur from Kochi, Kerala. More specifically, I can say from the southernmost state of India. My practice is very much limited to restorative dentistry and endodontics at Root Canal Point, Kochi, Kerala. In addition, I am working as a reader at Royal Dental College, Chalassery. So if I can describe myself, I am a combination of clinician and academician. Let me tell you certain things before I go into the presentation. Number one, I'm aware of the fact that the audience for me is having a mixed knowledge, because some may be clinicians, few may be academicians, there will be researchers, there will be postgraduates from my specialty department and there will be many more. So the knowledge all of you having in terms of this particular topic is very ambiguous. So what I had done is I had done my preparation taking into account of this fact, and hence I will try my best so that no one will be disappointed. Okay. The second point is the topic is endodontic irrigant, an evidence-based update. It's one of the hottest topic in the field of endo as of now, and that's because of few reasons which you will be understanding in the upcoming slides. Okay, and let this be very clear to all, that is, the topic is very much specific to irrigants in endo and not disinfection of root canal system, which will include many other factors other than irrigant. So this itself is a very vast topic. I had tried my best to keep a balance between evidence and practicality. So theory and practicality, hence please ask queries specific to the topic. So that will be my second request to all of you. The third is it will be a presentation spanning for more than 1.5 hours. Whenever I go okay, I'm not audible to you. Am I audible now? Please checking once more. Am I audible now? Okay. Okay, so I'm sorry about the audio quality. I will repeat once more what I had told you all. Good evening, everyone. I hope all are good and safe in your respective places. Let me brief a little bit about me. I am Dr. Jojo Kotur from Kochi, Kerala. More specifically, I can say the southernmost state of India. My practice is limited to the field of restorative dentistry and endodontics at Root Canal Point, Kochi. In addition, I am working as a reader at Royal Dental College, Chalassery. So if I can describe myself, I am a combination of clinician and academician. I need to tell few things before I go into the presentation. Number one, I'm aware of the fact that the audience for me is having a mixed knowledge. There are clinicians, there are academicians, researchers, postgraduates, and many more. So I had prepared my presentation such a way that I won't disappoint all of these groups. It's an evidence-based presentation. I will try my best to include both the clinical tips, practicality, and evidence. The second is the topic is endo irrigant, an evidence-based update. It's one of the hottest topic in the field of endo, and that's because of few reasons which you will be understanding in the upcoming slides. And a request for all of you is the topic is very much specific to endodontic irrigants and not disinfection, which include many other factors other than irrigants. So please ask queries specific to the topic. Okay. Number 3, it's a presentation spanning maybe more than an hour, maybe 1.5 hours. Generally, when I go for presentation in various platforms, I'll be lacking time. So here I will not be lacking time because I am the whole authority in starting and stopping the presentation. So my advice to all of you is grab some snacks as refreshment, just like the way I had done. Number 4, and the final note for all of you, is that I would like to add this particular note that's very important. I'm not a full-time researcher in endodontic irrigants, okay, that you need to realize. In my knowledge, there are 5 endodontists from India who does amazing contribution to the world of endodontics in irrigation. And I would like to list out the name of all those 4 or 5 endodontists. I would say more specifically 4. First will be Dr. Anil Kishan. He is from Kerala, now settled in Toronto. He is doing well in terms of endodontic disinfection. The second is Dr. Prasanna Neelakantan from Chennai. He is also doing an amazing job and contributing well in the upcoming field of irrigation. The third is Dr. Vasudev Bellal from Manipal, again from Karnataka. I had got a lot of input from Ballal sir, a very supportive person, and please, I'll be talking more about these people. And the last one is of course Dr. Gopi Krishna, my own teacher. So with this acknowledgement for all these stalwarts, let me take all of you into the presentation, and I would like to begin it with a very small story, and that's about nickel titanium rotary files. Okay. These nickel titanium rotary files were introduced into the market by 1990. So when this file was introduced into the market, everyone thought this is the silver bullet that is going to revolutionize the treatment outcome. You know why? I don't know how many of you can imagine the scenario, because at that point of time, there is stainless steel who does the job. It's very strainful, the file is not flexible, and all of a sudden all the clinicians and researchers got this file which is works in rotary. It is having a different color, it flex, and it is having very, very variable taper. So in all sense, clinicians and researchers thought this rotary file, the nickel titanium rotary file, is a silver bullet that is going to change the treatment outcome. Now this belief was continued for a decade from 1990 to 2000 till a brilliant clinician and researcher called O. Peters published a couple of articles in Journal of Endodontics and Journal of Dental Research in 2001 and 2000. Now these articles had become the nidus for the belief that the rotary files is not going to improve the treatment outcome. Now what he had done is he had taken pre and post of images before and after RCT, and he had combined both of it, and where the rotary files are touched is marked as red, and where the rotary file hadn't touched, it's marked as green. So you will appreciate that the green is more than the red. And these articles had become the nidus for all the clinicians and researchers to have a second thought that ease rotary file is going to increase the treatment outcome. Now this is even more complex as you go from left to right. That means from less complex to more complex tooth. So as the complexity increases, the untouched area also increases. So what does the rotary file does? The rotary file does is it only creates beautiful round shapes. So you can see in this picture, this cross-sectional image, you can see that the round shape is being created by the rotary, and there is a lot of untouched area. And to adding on to this complexity, there is something called apical delta. I don't know whether all are aware about the fact of this apical delta. Apical delta is nothing but it is a branching of the primary canals into n number of canals and exciting foramens at the apical 1/3. Now because of this apical delta, That is the rationally this is the rationally why when you do root resection in periapical surgery, we will be chopping 3 mm from the root tip, because we want to remove as much as the delta as possible. So apical delta is somewhere that the rotary file is not going to reach. Now here comes the conclusive statement from all the slides which I had shown you. The statement is nothing but, where the files cannot reach, someone can reach there, and the answer is irrigants. So I would like to emphasize this statement to all of you once more. Wherever files cannot reach, the irrigants can reach. Now, by 2000, clinicians and researchers had understood this fact. What are those facts? One, the files cannot reach into all the areas of root canal system. Second is the fact that when there is a lot of untouched wall, it will affect the treatment outcome. Now this is a point where all these kill and clean system had evolved into the dental practice. Now if you look very carefully, before 2000 there is not much advancement in the field of endodontics. We still have that sonic, ultrasonic and syringe irrigation. Now once this All Peters article is being published from 2000 onwards, there were a lot of published articles, research and innovation in the field of irrigation, starting from machine assisted agitation, continuous irrigation, apical negative pressure, photoactivated disinfection, nanoparticles, laser, gentle wave and many more. So when you classify endodontic irrigants, you can classify in n number of ways. Now, if you look into the textbook, you will see that it is classified into many ways, in many classification, and things are more complicated and confusing, just like the way what you can see in this slide. So let me make it very simple for you. I'm making the classifications very simple, okay? We need to remove 3 things from the root canal system. 3 things. One is the organic tissue, which includes the pulp, the degenerated or necrotic tissue, and to some extent you can say the pulp also, the biofilm. All those things are organic tissue. So the number 1 is organic tissue. Number 2 is the inorganic tissue. The inorganic tissue includes the dentine shaving. When you do the rotary file, there will be a lot of dentine debris that is collected inside the root canal. So that also have to be removed in the process. So that is the inorganic tissue. The third is obviously the bacteria. So the bacteria also have to be removed. So there is only one irrigant in the field of endodontics that can dissolve and remove the organic tissue, and that is sodium hypochlorite. Okay, and the irrigant that can remove the inorganic debris, which are the dentine debris, are some form of chelating agent. The most commonly used chelating agent is EDTA. And if you want to kill the bacteria, obviously you need to have some bactericidal agent. You can use either chlorhexidine or hypochlorite. So this is the classification which I would like to give it to you. It's very simple. Irrigants that will remove the organic tissue, irrigants that will remove the inorganic tissue, and irrigants that have the ability to kill and destroy the bacteria and the biofilm. Now let me ask you a question. Which is the most commonly used irrigating solution in the field of endodontics? Many may say it is hypo or chlorhexidine or something else, but I would say in India it is the saliva. You know why? Because I'm sure that many of you are doing root canal without rubber dam isolation, and you may be thinking, you will be asking the patient to spit in between, the patient will come back and the pulp chamber will be flooded with saliva. You will be doing the instrumentation with the saliva inside the pulp chamber. Now you should not say I didn't do it. Even I had done it if you're doing without rubber dam isolation. So saliva should not be used as an irrigant inside the root canal system. okay. You know why? Because saliva have a lot of pathologic microorganisms, and that can hamper the treatment outcome, even though there is no evidence for that. Now, according to evidence on various articles published in Journal of Endodontics, worldwide survey, 90% of clinicians use hypochlorite as a primary irrigant. And my teacher Gopi sir also published a similar article in Journal of Conservative Dentistry. According to his survey, also 90% of clinicians use sodium hypochlorite as a primary irrigant. Seeing this result, I'm very happy, to be honest, but I don't know the reality of it. Now let's discuss the aims of root canal irrigation. Now there is simultaneous but two distinct effects for all the irrigants. Now these effects are chemical effect and mechanical effect, as you can see in the picture. Now what are the objectives of chemical effect? The objective of chemical effects is as follows, that is, it have to destroy, kill and remove the biofilm, microorganisms, endotoxins and pulp tissue remnants. So those are the chemical effects of irrigants. Now, which irrigants does this? It is primarily the hypochlorite, and also chlorhexidine will help in doing or achieving these objectives. What about the mechanical effect? The objective of the mechanical effect is to detach or remove all of the above. All of the above means detachment and removal of biofilm, microorganisms, endotoxins and pulp tissue remnants. In addition to that, mechanical effect in help will remove the dentine debris, which is the inorganic tissue. Now, which all irrigants will help you in doing the mechanical effect? It is obviously the saline and EDTA. Now, let's see what are the factors which influence these effects. When it comes to the chemical effect, concentration, time and area of contact is a primary factors which influence these objectives. When it comes to the mechanical effect, the only factor which influences the mechanical effect is the pressure. What do you mean by that? It simply means that how good or how much pressure you can give to the barrel of the syringe, that much good will be the mechanical effect. So that's the importance of giving some pressure onto the barrel so that the mechanical effect is being elevated. So let's discuss all the primary irrigants first, and we will start with sodium hypochlorite. When you talk about sodium hypochlorite, we need to talk about these factors. First is the concentration. So how much concentration should be used? So when you talk on literature, I would say according to the literature, they had tested 0.5 to 8%. Now, to be honest, I hadn't seen an 7% or 8% hypochlorite in the market. But if you look into articles, they had done a lot of research with 8% hypochlorite. Now, second is the volume. So this is the most critical factor than the concentration. Many people think that concentration is more important than volume, which is not correct. According to me, volume is the factor which matters a lot in terms of treatment outcome. You know why? Because the hypochlorite will be neutralized very fast by the dentine's buffering ability. So you put hypochlorite into the root canal, within seconds, the effect of hypochlorite, the chlorine, the amount of chlorine in the hypochlorite will be diminished. So that's the importance of volume. The third is the time. Time is very misinterpreting, to be honest. You know why? Because I know clinicians who will finish irrigation in 30 seconds, and I know clinicians who finish irrigation more than 30 minutes. That means more than 30 minutes they will keep on doing irrigation inside the root canal. A classic example is my good friend Dr. Jaydev. I will be speaking more about his cases in the upcoming slide. The fourth is the depth of penetration. What do you mean by depth of penetration? It simply means that how much into the dentinal tubules. You know that inside the root canal also there is dentinal tubules. So the bacteria can hide inside the dentinal tubules. The bacterial size is much smaller than the dentinal tubule size. So it is imperative that our irrigant have to penetrate little into the dentinal tubules, and according to various studies, hypochlorite can penetrate from 77 to 300 micrometer into the dentinal tubule. That is probably around 0.3 mm. And the last is the effect on biofilm. Now this is the most important aspect as far as hypo is concerned, because it is the only irrigant that can destroy the biofilm. Okay, this is the only irrigant that can destroy the biofilm. Now I need to tell a little bit more about biofilm here. You know, biofilm is an organized community of bacteria. It have multi-layered defense, like layer 1, layer 2, layer 3, just to make it simple. But in order to create a biofilm or form a biofilm, the biofilm need a scaffold or a skeleton. You need a skeletal frame in order to arrange these bacteria in order. So these biofilms skeleton is made up of something called extracellular polysaccharides. Now these extracellular polysaccharides can be destroyed only by hypochlorite. So all of you, please remember this fact, that hypochlorite can destroy the skeletal structure of biofilm. Other than killing the bacteria inside the biofilm, it can destroy the skeletal framework of the biofilm. Okay, so that is the fifth factor, that is the effect of biofilm, effect of hypochlorite on biofilm. Now let's discuss how we can improve the efficacy of sodium hypochlorite. Now there are 4 or 5 ways to improve the efficacy. Number 1 is warm the hypochlorite. So please don't heat the hypochlorite, because it is just like ordering hot water when you go and have food from a hotel. If you ask for hot water, they will give boiling water which is not drinkable. Instead, if you ask warm water, they will give you water which is around 45 to 50 degrees Celsius. So warming hypochlorite means you need to increase the temperature by around 10 degrees from the room temperature. That will take the hypochlorite temperature somewhere close to around 45 degrees Celsius. And warming the hypochlorite will improve the efficacy of hypo. So that is the first method. The second method is ultrasonic activation. You activate the hypochlorite with some means, either sonic or ultrasonic. It will improve the efficacy. And studies had also proven that when you activate the irrigants, hypochlorite, the activation itself will improve the temperature. That means there is a temperature rise of 5 to 10 degrees. So ultrasonic activation, other than improving the efficacy, it indirectly add on to it by warming the hypochlorite. I hope you understood what I was trying to say. The third is a refreshment. What do you mean by that? You continuously do the refreshment and the efficacy of hypochlorite is increased. So the reason, I hope all of you know, because there will be a lot of buffering action from the denting. And the last is the exposure time or retention time. We can also call it as retention time. I mean, how much time the hypochlorite is in contact with the root canal system. If you can give more time, there will be more efficacy. So these are the 4 factors which influence the efficacy of hypochlorite. Now a clinical picture just to show you the importance of pulp chamber and pre-endodontic buildup. Now what these things does is it creates a chamber like thing, so that the irrigant can act as a reservoir there. So whenever I do rotary instrumentation or any sort of instrumentation, I always put hypochlorite inside the chamber, so that this will act as a reservoir for the fresh irrigant to be pushed into the root canal system. Here you can see in this video that when I am doing rotary instrumentation, it's not that focused, but you can see from the file tip it is a combination of irrigant and debris. So please make sure that when you do any sort of instrumentation, whether it is hand filing or rotary, make sure that you put some irrigating solution inside the pulp chamber, and I would prefer hypochlorite. Now let's discuss a few articles, more specifically 2 specific articles. Number 1 is this. It's a beautiful article which assesses the chemical biofilm removal capacity of endodontic irrigants. So what they had done is they had assessed the primary irrigants for its biofilm removal ability, and what they concluded is when NaOCl is used as a primary irrigant, it can destroy the biofilm. The reason which I had already told you, because it have the NaOCl have the ability to destroy the extracellular polysaccharide. Okay, when they assessed with EDTA, what they understood is that EDTA also will destroy the biofilm, but it will destroy only the extracellular polysaccharide poor biofilm, because there are few biofilms which doesn't have the skeletal framework. So if you don't have the skeletal framework, from their study they say that EDTA have the ability to remove the biofilm, but specifically saying EPS poor biofilm. But what happens when they use chlorhexidine? When they use chlorhexidine, what they found is the biofilm is not removed, but rather it is being rearranged. So it is something like a mutation. So preferably avoid chlorhexidine in targeting if you are targeting to remove the biofilm. Okay. The second article, it's also a beautiful article shared by my senior Venkatesh Babu sir, published in Journal of Endodontics last year, and they assess the root canal disinfection ability when using hypochlorite, and when we use multi-file system, higher volume and long retention time. And the conclusion what they made is that when you use multiple files, there will be an increase in disinfection. When you use higher volume, there is more disinfection, and when you increase the retention time, again the disinfection is more. So this highlights the facts that multi-file system will always give better disinfection, because after each file you will be pumping irrigant into the root canal system, so obviously the contact time of the irrigants will be more. So to summarize about sodium hypochlorite, I can say the 3 things which is the most important factor as far as hypo is concerned. Number 1 is the concentration, number 2 is the retention time, number 3 is the volume. More to summarize, it is the most important irrigating solution in endodontics, and it is the only irrigant that can capable of removing organic tissue, biofilm and organic part of smear layer. Next we will move on to chlorhexidine. So when I used to go for consultation initially, whenever I asked for chlorhexidine irrigant, many clinicians used to give these mouthwash. Now never use mouthwash chlorhexidine as an irrigant, because mouthwash chlorhexidine percentage is very less. It is 0.2%, whereas the chlorhexidine, which is being marketed as root canal irrigant, is having a concentration of 2. So there is a lot of difference between these two. If you use a mouthwash chlorhexidine which is of a lesser concentration inside the root canal, nothing else will be happening other than all the bacteria will be happily smiling back to you. But on the contrary, if you use 2% chlorhexidine as a mouthwash, what will happen is the next day you may get oral candidiasis or oral thrush. You know why? Because the 2% chlorhexidine is so potent that it will destroy the normal flora of your mouth. So the 2 important factors as far as chlorhexidine is concerned is that it inhibits the matrix metalloproteases. You know what is matrix metalloproteases? This is something that will inhibit the bonding. So if you want good bonding to the dentine, you need to inhibit this MMP. So chlorhexidine is a potent MMP inhibitor that many studies had proven that. The latest study is from Journal of Adhesive Dentistry. Another beautiful feature of chlorhexidine is the substantivity. Now, what do you mean by substantivity? Substantivity is nothing but what is EPS poor biofilm. What I understood from Sonam had asked this doubt, that is, what is EPS poor biofilm? EPS poor biofilm is nothing but the biofilm which is lacking the skeleton of extracellular polysaccharide. That is what we mean by EPS poor biofilm. Okay. Moving on, the second important factor of chlorhexidine is the substantivity. Now, what do you mean by substantivity? Substantivity is nothing but the chlorhexidine molecules will be absorbed by the hydroxyapatite crystals, and its residual antimicrobial activity will be there for weeks to months. It's a beautiful property, right? That means if some bacteria is hiding inside the root canal somewhere, whenever they come out, they come in contact with the chlorhexidine molecules, the chlorhexidine molecule will kill it. So this is a beautiful property which is not being seen in any other irrigants in endodontics. So two important property as far as chlorhexidine is concerned, as far as irrigant is concerned, is it can inhibit matrix metalloproteases, which helps in bonding, and second is it have a beautiful property called substantivity. Now, what about the disinfection ability? Now, these articles had shown that sodium hypochlorite is better than 2% chlorhexidine in terms of biofilm removal and also in terms of disinfection. There are many more articles stating this theory. Now, there are few contrary results also that is saying that 2% chlorhexidine is having better disinfection property than hypochlorite. Now, let's see a systematic review of clinical trials and meta-analysis by Prasanna sir, published in International Endodontic Journal 2019. Let's see what they conclude. He concludes that sodium hypochlorite reduces endotoxins level better than chlorhexidine. This systematic review assessed only the endotoxins level, and they've taken into consideration only the clinical trials and meta-analysis. And the conclusion is NaOCl is far better than chlorhexidine in terms of reduction in endotoxins level. Classic article from NG et al. Is one of the most cited articles in endodontics now, the outcome study. And according to her research, she concluded that chlorhexidine as a final rinse may delay the healing of apical periodontitis. That is really surprising, because we all used to do chlorhexidine irrigation for a long period of time, and the outcome study says that when you push chlorhexidine beyond the apex, it will affect healing of periapical wound. Now, to conclude or to summarize about chlorhexidine, I can say that it have less antibacterial effect and it will delay the wound healing. Less antibacterial effect means when you compare with hypochlorite. Otherwise, it's a potent antibactericidal agent. Okay. So when you compare with hypochlorite, recent evidence suggests that hypo is better than chlorhexidine. And the classic NG et al. Article says that it delays the wound healing if you use the chlorhexidine and push it towards the periapex. So the question that we need to ask now is, do we need to have chlorhexidine as an irrigant during RCT? Do we still want to use it? And the answer to that is this. The summary about chlorhexidine: My indications for chlorhexidine is very specific. I will use only chlorhexidine as a final irrigant if there is a heavily infected canals and especially in terms of re-root canal cases, because the chlorhexidine is shown to have very potent effect on efficacy. So I would like to give a final wash with chlorhexidine before going for the obturation, especially in infected canals and also in retreatment cases. My second indication of chlorhexidine is in open apices and in case of large perforation where there is a risk for extrusion of NaOCl. You cannot use NaOCl in open apices because it can push hypo beyond the apex and can lead to hypo accidents. So when you deal with open apices, a final wash with chlorhexidine have an added advantage, because I had told you before that it is a potent MMP inhibitor. So it will improve the bonding, and in restorative dentistry we do something called intraradicular rehabilitation. And in intraradicular rehabilitation we will try to bond the root canal system with some sort of resin cement, and obviously because of the inhibition of MMP, that resin bonding to root dentin will be improved. So my indication for chlorhexidine is two. Number one, in infected canals and in re-root canal cases. Number two, in open apices and perforation repair. But you need to understand the fact that 2% chlorhexidine solution is an alternative irrigant, but it certainly cannot replace hypo. Okay, so this is a fact that you need to realize. Our primary irrigant should be always hypo. This is a secondary irrigant, and this indication is being listed out in the bottom aspect of the slide. The third irrigant obviously is the saline. Now whenever I talk about saline, I will speak on pressure. You know why? I hope you remember the maybe 7th or 8th slide, which I had explained the mechanical effect of the irrigant. The mechanical effect will only happen when you irrigate with pressure. Now, whenever you irrigate saline, please make sure that you irrigate with a lot of pressure. So the first objective of saline is to mechanical effect in removing the debris and the smear layer, which is achieved with the help of pressure. Now the second objective is for the saline is it neutralizes the effect of other irrigants. You know, these primary irrigants, that is hypo, chlorhexidine and EDTA, doesn't mingle each other. It doesn't like each other. You know that when some people are in the top level, I mean 1, 2 and 3, even though they smile each other, inside the heart they don't like each other. That is a fact of life. So something like that. The primary irrigants always have an internal politics, so they don't like to mingle each other. So the second purpose of the saline is to neutralize the effects of the primary irrigants. So whenever you use a primary irrigant, in order to use a second primary irrigant, which is what, for example, if you use hypo, if you want to put EDTA there, you need to wash with saline to neutralize the effect of the sodium hypochlorite. So the third action of saline is it helps sealer adhesion. I'm not going into detail about sealer adhesion and irrigation regime, because that is again a PhD topic, and I'm quite sure that Prasanna sir will be the pioneer in that, because he is the one who done his PhD in that topic. But I can summarize by saying that all the primary irrigants except chlorhexidine have effect on sealer adhesion. So it is better not to use, especially not to use hypochlorite as the final wash. All sealers will be compactable when you use saline as a final irrigant. Now it is also, evidence also says that chlorhexidine also can be used as a final irrigant. After saline, the least interaction to sealer is chlorhexidine. So my take home message to all of you from saline is it should be the final irrigant, especially when you're using hydraulic sealers. That means calcium silicate sealers, because all other sealers have some effect in the hydraulic sealers. But if you're using any other sealer, either you can stop with chlorhexidine or with saline. The fourth is a chelating agent. That's the fourth irrigant. I told you about the function of chelating agent. The function of chelating agent is nothing but to remove the inorganic debris. Now, chelating agents can be classified basically into strong chelator and weak chelator. Okay. Now, what are the strong chelators? Strong chelators are EDTA. This is the one which we commonly use, available from 15 to 17%. The second is citric acid, most commonly used is 10%. Chitosan nanoparticles also is a good chelator. Malic acid is a very good chelator. I'll be talking a little more about malic acid. And peracetic acid is also a strong chelator. So these are the strong chelator. What do you mean by strong chelator? Strong chelator is nothing but this will demineralize or erode the root canal dentin more aggressively. Okay, its chelation ability is more strong. The second is a weak chelator. There are many weak chelators in the literature, but the weak chelator which is in the limelight at this point of time is something called HEBP or etidronate. I'll be speaking about that also. Now, again, I'm putting this classic article regarding tooth survival from NG et al. Now, what she concluded in her treatment outcome study is that when you use EDTA a lot while doing re-root canal treatment, it improves the success rate. That is something new when I was reading this article, because I was thinking that you have to still use a routine irrigation regime in all the cases. From after this, I try to use EDTA a little more than usual in re-RCT cases. Now, you know why this finding had come? It is because EDTA is markedly superior in dissolving root canal sealers than NaOCl. You know, when you want to do a re-root canal treatment, obviously the root canal will be heavily contaminated, and the sealer inside and the GP inside will also be contaminated. So how good you remove these infected sealer and GP, that much predictable will be the treatment outcome. So it is very important that you use little more EDTA than usual when you use EDTA. Don't forget this name, Vasudev Ballal, when you are speaking about malic acid. He had done his PhD in malic acid and had found that malic acid is good in smear layer removal in terms of inorganic tissue. It have a good decalcification effect. Its bonding to resin is well, and it is less toxic compared with the predecessors. Okay, so these are the findings from his side, Ballal sir. So to summarize on strong chelators, I would say it should be used more in re-root canal cases, because according to evidence it says that from NG et al. And an article published in American Journal of Dentistry. And it is the only irrigant that can remove the inorganic part of smear layer, and also it enhances sealer penetration. How it enhances sealer penetration? Because it will demineralize the dentin and exposes the collagen. So all these methacrylate based or epoxy based sealer will have a better bonding. Again, Sonam had asked, after final rinse of chlorhexidine, no saline flushing is done before obturation. I'll be speaking about that in my last slide. Okay. When using chlorhexidine as final irrigant in vital cases, then when we can use EDTA by Ram Balaji. Sorry, I didn't understand the question. Okay, we will see that later. Moving on. Now let's discuss few combinations. Okay, how about combining chelator and NaOCl? Because without chelator you cannot remove the inorganic tissue. Without hypochlorite you cannot remove the organic tissue. So how about combining these two? So many people or researchers have tried their best to combine these two and make one single irrigant. They try to combine EDTA with NaOCl, citric acid with NaOCl, and malic acid with NaCl. And what happened is that when you combine these two irrigants, I told you these doesn't mingle well. The action of hypochlorite or the amount of chlorine ion in the hypochlorite decreases when these irrigants are combined. Okay, so as you can see in this article, what is being text boxed in the yellow is the interaction between sodium hypochlorite and citric acid, and sodium hypochlorite and EDTA, and you can see that it will have some interaction, and the amount of chlorine ion will be reduced when these two are combined. Now here comes the turning point. I told you now that till 2005 it is believed that a chelator and a sodium hypochlorite cannot be combined, because the previous research I had shown in the previous slides also I had shown that whenever you combine these two, it will counteract the action of one or more irrigant. Now the pioneer in irrigant research, Matthias Zender, he had published an article in 2005 named "Chelation in Root Canal Therapy Reconsidered." And what he had done is he had tried to combine the so-called HEBP or etidronite, which I have told you in the classification. He tried to combine HEBP or etidronite with sodium hypochlorite in 2005. And what he found at that time is the HEBP did not interfere with NaOCl. That means, unlike the other chelators like citric acid, malic acid, and EDTA, HEBP didn't affect the action of NaOCl. Later, his group had assessed the smear layer ability of this mix, and what they found is whenever you use this combination, that is the combination is a weak chelator and sodium hypochlorite. Whenever they use this combination, the smear layer is not at all formed. What do you mean by that? It simply means that they don't use this hypo and EDTA separately. Instead, throughout the root canal treatment, they used this combination of irrigant, one single irrigant, which combines both. And they found that the smear layer is not at all formed. You know why? Because there is continuous chelation in this scenario. Because of the weak chelator is continuously chelating, at the same time the hypochlorite is giving the tissue dissolution effect. So indirectly the weak chelator is helping the hypochlorite to act better. Okay. Now moving on, again the same group had assessed the hard tissue debris removal, especially from the isthmus area after rotary instrumentation, and what they found in 2012 is this mixer will reduce the hard tissue debris accumulation in the isthmus by a statistically significant percentage. Later, few researchers, especially Prasanna sir, had assessed the antibacterial effect of this combination, and what they found is that the mixture is good as NaOCl. That's a good finding, right? Because NaOCl is considered to be the best antibacterial agent and equal to chlorhexidine, and their research found that this mixture have an equal antibacterial action just like the hypochlorite. Again, Prasanna sir in 2012 had found that this mixture increases the bond strength of epoxy-based sealers, for example, AH plus sealer. That means if you use this as a final irrigant, it will increase the sealer addition. Also, he had found recently that in 2015 he found that the mixture can increase the bond strength of hydraulic sealers. So sealer addition to epoxy based sealers and hydraulic sealers are better if you use this mixer as a final irrigant or during the irrigation protocol. Later, Ballal sir, this is published last year. Sorry, I'm not cited the volume and year. Published in IEJ. He found that the ability of the etridronite to chelate calcium is not affected by NaCl. That is the other finding. Till now, all had studied the effect of NaOCl when it combines with etridronite. Now, he had done the other way. He found that this combination, when you use this combination, the etridronite lot of disruption. Okay, I am not sure about it. Jones, a lot of disruption. I am doing my best in terms of volume. If I am not audible, please put an earphone. I think that will be great. Another query is, sir, chlorhexidine saline used as final irrigant in both single sitting RCT and multiple sitting RCT, where observation is done in the next sitting, or will there be a difference? Yeah, obviously we will do this final irrigation protocol, which I'll be discussing later. I think I will be answering your queries in the future slide, Dr. Anand. How does laser works in root canal decontamination? I'll be speaking about it, Dr. Premalata. Thank you, Rupal. You are audible minimal. Thank you. Continue. Okay, continuing. Moving on, again, this article from Ballal sir had found that the ability of etridronite to chelate calcium is not affected by sodium hypochlorite. And finally, the randomized control trial. You know, when you put the priority on evidence, the randomized control trial is having the highest priority, because that is what will be beneficial for the patient. These in vitro studies won't be beneficial for the patients. Okay, Neha sir, can you briefly explain the current irrigation protocol? I'll be explaining it. Please wait. I'll be explaining my protocol in my final slide. Be patient, Neha. Okay, moving on. So what Ballal sir had done in this article is he had done a control trial on patients about this mixture, this combination, and assessed the antimicrobial efficacy, post-operative pain, the host response, and the finding is HEDP, which is this mixture, did not affect the clinical effects of NaOCl. So that's a beautiful finding. That's a hope for all of us. There is no need to do this NaOCl EDTA anymore. According to evidence, you can go ahead with this continuous chelation. Continuous chelation is nothing but a combination of sodium hypochlorite and weak chelator etridronite. Okay. Now, there are certain concerns about the stability of this mixture, to be honest. So until now I had spoken about the good things about this mixture. Now, this is also been found by Zender and team published in IEJ 2018. What they found is when you have to use it immediately once we had prepared the mix, because this comes as a powder this etridronate, you need to open up the capsule and mix it with 10 ml of hypochlorite, and you have to use it immediately. That's the research, that's the finding from their side. Or else the amount of chlorine available for the disinfection will be drastically reduced. They also found that heating of the mixture affects the available chlorine. So there is a technique of intracanal heating of sodium hypochlorite, which will improve the efficacy. So don't do that in this mixture, because according to their research, if you heat this mixture, on contrary to NaCl, it will decrease the available chlorine. So to summarize about this V chelator or this mixture, I can say there is no interaction with NaOCl. If it is fractionally mixed, this mixture doesn't have any interaction on NaOCl. And also NaOCl will not interact with etridronate. It can reduce accumulated hard debris in isomers, and it is good as NaOCl for its antibacterial action. In addition, it can enhance the bond strength of calcium silicate sealers and epoxy base sealers. Okay, so at this point of time, continuous chelation strategy looks promising. That's my summary about it. But only concern with this continuous chelation is that it is a weak chelator. So better the chelation, better will be the bonding to root dentine. So I'm a little skeptical about that finding, or else everything according to evidence works purely well in accordance with continuous chelation. Okay, let me take a break. Let me drink some water. Give me some time. By the way, there are a lot of questions. So, sealer, do you use in day-to-day practice? I use PCS sealer, pulp canal sealer in my day-to-day practice, because I use warm vertical compaction. Is it okay to use Clorox as irrigant? I'll be speaking about that, Madhu sir. Just stay tuned. Anita, best irrigant in case of periapical abscess, sir. There's no best irrigant. Obviously, you have to use a combination of irrigant. You will be understanding that in my last part of the presentation. Amrita, sir, please could you mention irrigation protocol for periapical abscess again? I will be answering that in my final slides. Again, is distilled water more noble than saline as final neutralizing irrigant? To be honest, I'm not aware about it. What I use is the normal saline. Benila Babu, thank you. Thank you, Bini. Suraj, sir, how EDTA lowers the effect of hypochlorite when used together? That is more of research and chemistry. I'm not boring all the audience with that explanation. Suraj, I will explain to you in person. Concentration of HEBP. So there is no concentration for HEBP. The concentration is not being cited. What they say is that the etridronate comes as capsule. So these capsules can be mixed in hypochlorite, and that a specific quantity of hypochlorite, and that can be used as continuous chelation. How much time of irrigation is adequate for hypo? That I will be speaking later. Neha, can we mix peracetic acid strong chelator with NaOCl? The research is yet to find that. Let's see that. Okay, so moving on, let's see the possible ways in making the irrigants reaching these target areas. Okay, We will start with syringe irrigation. Arun Kumar, hi Dr. Jojo, use of bioceramic sealers. I'll be speaking about that later. We will discuss all these queries in the final part of the presentation, okay? So moving on, the three essential components of all positive pressure irrigation are you have to use a Lure-Lock syringe. You know what is Lure-Lock syringe? Lure-Lock syringe is nothing but you need to screw in the needle into the syringe. The attachment is that way. It is not friction grip. The second, you need to have a rubber stopper. Rubber stopper towards a working length, and you have to have a side vented needle. Okay. So when you talk about Lure-Lock syringes, the syringes are available from 2.5 ml to 20 ml, as you can see in this picture. So which one you should take? Now for that we will go into little bit of mathematics. So we have to choose 5 cc syringes for all root canal irrigation, and I will tell you why. So this is max P equals F by A. That means the area is inversely proportional to the pressure. You know, if you want to increase the pressure, that will increase the mechanical effect of many irrigants, and irrigants obviously have a mechanical effect. So P is a pressure developed inside the barrel, F is the tactile force that you apply to the syringe plugger, and A is the cross-sectional area of the rubber plugger. Now, as A increases, the pressure decreases. What do you mean by that? If you use a 20 cc syringe, however good you are, I mean, whether you you go for gym bodybuilding, or whether you have a lot of power or muscle power, it doesn't make any sense. There is a limit to which you can give the pressure. So there's a limit for giving the pressure with a large cc needle. So that's why we don't want this 12 cc and 20 cc syringes. But you don't want this 2.5 ml also, cc also, because obviously it have lesser cross-sectional area of the plugger, so you can give more pressure, but the irrigant will be drained very fast. So you get that combination only with the 5 cc. So that is why I will strongly advise to use 5 cc syringes for all sort of irrigation. So good pressure means good flow rate. So flow rate is generally expressed in milliliter per second. So these are little into theory, but I feel this is very important for understanding the syringe irrigation. So I already discussed one factor, which is the pressure. The pressure is very important for syringe irrigation, and pressure, we give good pressure, you get good flow rate. Now when you talk about flow rate is also having some factors which determines the flow rate. Now there are many factors, from internal diameter to length of needle to viscosity of the irrigant, but what we are concerned is the pressure difference along the needle barrel. It is directly proportional to the flow rate. What do you mean by that? It means that if you give more pressure, you get more flow rate. So that's the nutshell of it. And also we need to learn a little bit about turbulent flow and laminar flow. What do you mean by turbulent flow? It is fluid mechanics. So turbulent flow is something like this picture. Fluid moves in irregular path or layers. That means it's having a disturbed flow. Whereas the laminar flow means the fluid moves in smooth paths or layers. That means it travels in a uniform path. You can witness that in certain taps, in high-end taps, they will give a laminar flow, whereas if you go for cheaper quality taps, they generally give a turbulent flow. So in irrigation, in endodontics, we need a laminar flow because it gives a steady flow of irrigant. More volume is being pushed out if we can achieve a laminar flow. And the studies had proven that when you when you have a flow rate of 0.01 ml per second, you get a steady laminar flow. Please listen to this very carefully, okay? Because it's very important to understand the physics of syringe irrigation. What they say is, in order to achieve steady laminar flow, which is our primary objective, you need to have a flow rate of 0.01 ml per second. Now, the point you reach 0.26 ml per second, you go to unsteady laminar flow. You are still in laminar, but things become unsteady. Now, the point where you reach 0.5 ml per second flow rate, you get a turbulence flow. So out of all these three, we want our irrigation regime to be done in a flow rate somewhere close to maybe 0.01 to 0.2 ml per second. So I had done my trial, and according to my trial, the flow rate what I achieved with a 5 cc syringe, a 30 gauge needle, the flow rate which I had achieved is 0.1 ml per second. That means I am still in the laminar flow. So please try this out in your clinic. What is your flow rate? Because that will help you to do a better irrigation protocol. Now, moving on to the needles. Needles can be broadly classified into open-ended needle and side-wended needle. Towards your left, 1 and 2 is an open-ended needle, wherein the opening is towards the tip, 1, 2 and 3. And the right side is a closed-ended needle or multi-wended. The closed-ended needle is nothing but the venting is towards the side. And the last picture is a beautiful needle from Endovac, multi-vented. You also have to realize the fact about a factor called jet. What do you mean by jet? Now, in hydrodynamics, jet is defined as high velocity fluid stream forced out of a small diameter opening, just like this picture. You can see when you go for car washing, you can see the jet of water coming out through a small nozzle. That is exactly called the jet. Okay. Now, when you irrigate inside the root canal system also, there is a jet of water coming in a similar fashion. But that's happening inside the root canal system, so we may not be seeing that. Okay, so I hope everyone knows a little bit about fluid dynamics. Fluid dynamics is nothing but it's a study of the movement of fluids. It's a computer generated study. That means the computer will show you the path of fluid movement. Okay, so this is a classic study. What they had done is they had kept all the needles, 1, 2 and 3 towards the left are open-ended needle, 4, 5 and 6 are closed-ended needle. Okay, so they had kept all these different needles at 5 mm short of the working length. Okay, all needles are kept 5 mm short of the working length, and they had tried irrigation with the flow rate which will give you a laminar flow. And according to fluid dynamics study, what they understood is the irrigant from the open-ended needle will be pushed only 3 mm from the tip of the needle inside the root canal system. If you ask me, this won't be the scenario if you irrigate outside the root canal system. You give me a open-ended needle, syringe and needle, I can forcefully inject the solution to probably more than a meter. But this won't happen in a closed system because there are a lot of pressure factor working inside the root canal system. So what they found is, you can see it here, from the needle tip, from all these needle tip, the irrigant will go only 3 mm and it comes back. So you can see beautifully drawn picture of fluid movement according to fluid dynamics here. But if you use the closed-ended needle, you can see the closed-ended needle here, the irrigant will be pushed only 1 mm from the needle tip. It won't be moved any further. Okay, so these spaces, what is left behind is called the dead space or stagnation zone. That means Here there is no replenishment of the solution. Here also there is no replenishment. So here there is almost 4 mm of stagnation zone. Here there is around 2 mm of stagnation zone. Okay, moving on. This is a ISO standardization of various syringes, the various needles. You can see the gauge size there, 21, 23, 25, 27, like that. So the most commonly used irrigating syringe needle in all clinical practice is the 23 gauge, and generally we have a habit of taking the same syringe and needle that we are used for injection. Don't do that. Please try to take a fresh syringe and needle for injection. So if you look into the 23 gauge needle, which is a commonly used irrigating needle by all practitioners, because that's exactly the syringe that you use for injection. So if you look into the outer tip diameter of this needle, you can see that it is 0.67 millimeter, which is equal to number 70K file. You know the tip diameter of number 70K file. No? Number 70K file tip diameter is 0.70 mm. So a 23 gauge needle tip size and a number 70K file tip size is almost same. So keep this in mind, and now we will move on to this diagram and listen to me very carefully. Generally, majority of the preparation will be ending with 2606 and taper enlargement. 06 means 6%. Now, if you prepare the root canal with 2506, that means at 0 mm from the working length, you have a tip diameter of 0.25. 1 mm from at 0 mm here, it will be 0.25. 1 mm from the tip, it will be 0.31. You know why? Because 0.25 plus 0.06 is 0.31. According to mathematics, it is said that 6% file, there is every 1 mm, there is an increase of 0.06 mm. So 0.25 plus 0.06 will give you 0.31. So this calculation, when you go, this is how your root canal preparation ends. And imagine you putting a 23 gauge needle, which have a tip size of 0.67. It will be going around maybe 6 to 7 mm short of working length. And this will be more complicated if you have a curved canal. And you try to inject with an open-ended needle, the irrigant will go 3 mm, and what you get, the last 3 mm or 3.5 mm from the working length is the stagnation zone or the dead zone. Now here let me ask you a very important question. Which is the most important area as far as root canal system is concerned in terms of cleaning? It is the apical 1/3, because that is where all the anastomosis, all the apical delta is present. Now what happens here is the most critical area is not cleaned, because that becomes a stagnation zone. Now here comes the importance of a 30 gauge needle. So it's very imperative that you use the 30 gauge needle for final irrigation, because the 30 gauge needle will be going from here to somewhere around 2 to 3 mm short of the working length. And you know, when you use an open side vented needle, if you keep it 1 to 2 mm short of working length, it will be very efficient, because according to fluid dynamics, the irrigant will be pushed maybe 1 to 2 mm from the tip. So if you're using a closed-ended needle, the best option is you need to keep the needle 1 mm short of the apex. Okay. If you're using an open-ended needle, you can keep it 3 mm short of the apex. But the problem is the open-ended needle is not recommended in clinical practice. There's a lot of queries. Okay, I shall answer all these queries after finishing the presentation, because the queries will be interrupting my flow. Okay, I hope all of you can understand that. So moving on, the open-ended needles are not recommended in clinical practice because there is a high chance of extrusion. So conclude about this tip size of the needle, we can say you have to use minimum 30 gauge side-wended needle, and this needle have to go 1 mm from the working length in order to give a predictable result. Now there is a problem with this. If you want to keep the 30 gauge needle 1 mm from the working length, you have to enlarge the root canal system to a size 30 or 35. And according to this study, it shows that syringe irrigation will be effective only if you take the enlargement to 30 or 35. So that's a problem now, because I had spoken all about the advantages of a 30 gauge needle and its betterment in treatment outcome, and all of a sudden you will realize the fact that in order to achieve it, you have to enlarge the canal to 30 or 35. So if you enlarge till 30 or 35, you get good cleanliness as far as syringe irrigation is concerned. Now the problem is increased size of preparation is it will create more micro leakage, it can lead to transportation, it can weaken the root, and also there is a chance of vertical root fracture. It's proven that when you use larger size preparation, vertical root fracture initiates from the root apex. So larger preparation, there is always more prone for vertical root fracture. Also, there are few outcome studies, or probably I can say literature review, which says that if you improve the size of your preparation, that means the master apical size of the preparation from 20 to 30 to 35, it gives better treatment outcome. These studies says that way. Also, in a histological study in rats, it's a histological and radiographic study published in IEJ 2018, they found that larger apical enlargement protocols favored a more rapid radiographic repair of apical periodontitis. So that is again making it more challenging, because we don't want the root canal have to be enlarged much, but evidence says that especially when you have apical periodontitis, you need to enlarge the canal more, and that's why you get better treatment outcome. This is an in vivo study. And finally, the randomized control trial had come from India. Sanjay Tiwari sir and team had published this in Journal of Endodontics 2012. And what they found in the randomized control trial is enlargement of canal to 3 size larger than the first file that binds to the apex is adequate, and further enlargement there is no added benefit. Now this is totally surprising. You know why? Because in all these literature review and in meta-analysis and in vitro studies and in vivo studies in animals shows that you enlarge more, you get better treatment outcome. And when you come to human clinical trial, they found that there is no added benefit in additional enlargement. So to summarize about apical enlargement, taper and treatment outcome, I can clearly summarize this way. At this point of time, there is inconsistent evidence in relation to all these factors. Moving on, we have to learn little bit theory about wall shear stress. What do you mean by that? Wall shear stress is nothing but it is a frictional force occurring between flowing irrigant and root canal wall. I don't know how good I can explain this, but this will determine the mechanical effect. So wall shear stress is very important as far as mechanical effect is concerned. This picture will help you to understand it better. You can see that the higher wall shear stress is only being produced close to the needle tip, or where the the syringe solution is coming out. Okay, so it is very much limited to the area near to the needle tip. That is why we generally say you need to move the needle along the root canal wall. When you do the final irrigation protocol, you should not keep it all the way to the 1 mm short of the working length and irrigate continuously. Rather, move it up and down so that the root canal system will get the wall shear strength in the entire length. You got it? But there's a problem here. When you do it clinically, your needle will be positioned towards one side. So your wall shear stress will be coming only to that side. So ideally, you need to rotate the needle in order to achieve the wall shear stress in a 360-degree manner. So there are 4 challenges for syringe irrigation. Okay, the challenges that has been faced by syringe irrigation are: 1. Dentinal tubule disinfection. I told you dentinal tubules also contain bacteria. You can see in this picture nicely a lot of bacteria is occupying inside the dentinal tubules. So how good the syringe irrigation can remove it? It's questionable. 2nd, apical delta penetration. It is questionable. 3. Biofilm removal. It's questionable. 4th, isthmus cleaning. That's also questionable. So these are the 4 challenges of syringe irrigation, and there are many studies which clearly shows that traditional needle irrigation fails to clean these 4 areas which I had mentioned before. And that's the importance of activation system. There are various activation systems, and researchers had believe that when you activate the irrigant, it makes some sort of tsunami effect, and this will push the irrigant into these imperfections of root canal system. So we will start with manual dynamic agitation, or MDA it is called. Now, what do you mean by MDA? What we have to do in MDA is you have to take a well-fitting GP. What do you mean by that? Well-fitting GP, again there are queries. Okay, moving on. You have to take a well-fitting GP. Well-fitting GP means you need to take a GP which matches the size and taper of the last master apical file. That is a master cone, for example. So if you are prepared with 0625, you have to take an 0625 GP. That is a well-fitting GP. Now there are few authors which says that you need to take a lesser taper GP, but I generally don't follow it. I take a well-fitted GP, that is the GP that matches the tip diameter and taper of the last master apical files which I had used for preparation. You have to put hypochlorite inside the canal, and these GP have to be moved up and down in 2 to 3 mm amplitude, 100 strokes in 30 seconds. Okay. Now what it creates is it creates a frequency of 3.3 Hertz inside the root canal system. So let me show you a video of it. This is a video. It's not that difficult. You don't need to invest anything. All you need to do, all we need to have is some attitude and a GP. That's it. This GP should not be used as a master cone. You have to discard it. Okay. So this is how you do it. I'm repeating once more. Take a well-fitting GP, move it up and down in 2 to 3 mm amplitude, 100 strokes in 30 seconds. Okay. Next activation method is sonic. Now, I told you MDA will create a frequency of 3 Hertz, but when you come to sonic activation, the frequency that it can generate is 6 kilohertz. Okay, the pioneer among the sonic activation is Micromega Sonic Air, which I had used during my post graduation also. The advantage of this handpiece is it can be attached to your routine air rotor attachment. Okay, and it can be, you can buy this RIPC sonic file and you can activate the irrigant. So the modernization of that came up a decade back from Densefly. It is called endo activator. I find two advantages for this. First, it uses a polymer tip, so it can go into the curvature. Second is it is very handy. So if you are going for consultation, you can take it and use it because it's a codeless device. The third is something called the Vibranch system. I hadn't seen this system till now, but what it does is when you try to irrigate, you can see the specially designed syringe. This will create sonic vibration towards the needle. So these are the sonic activation devices, which includes the micro mega sonic air, the endo activator, and the Vibranch system. The third is ultrasonic. Now, first let us discuss about the frequency. The frequency jumped to 30 kilohertz. I told you the MDA had produced 3 hertz, sonic had produced 4 kilohertz, but when it comes to ultrasonic, the frequency had jumped to 30 kilohertz. Now there is a difference between UI and PY. UI means simultaneous ultrasonic irrigation and instrumentation, whereas PUI means passive ultrasonic irrigation without instrumentation. So we don't want the instrumentation during the activation, because when you instrument, again more of smear layer is produced. We don't want that. So what we follow now is the PUI, passive ultrasonic irrigation, and from now onwards I'll be using PUI. So you have to remember PUI means passive ultrasonic irrigation without instrumentation. Now there are various tips to do this. Woodpecker produces this E1, E2 tips, comes in 95 degree and 120 degree. And you have to be specific with these tips because E1, E2 is compatible with Woodpecker series ultrasonic units. Whereas if you are having a satellite unit, you have to buy ED1, ED2 because the satellite follow one chuck system, whereas the Woodpecker follows the EMS thread system. So both thread systems are different. And the file that you can attach to these Woodpecker tips are called the U files. It is called the U files, and you can buy it from Money or you can buy it from Woodpecker, and is available of different sizes from number 15 to number 40. It is available. Okay, what are U files? U files are nothing but a K file without handle. So this can be attached to that ultrasonic tip, this ultrasonic tip, and you can activate it. But please make sure that you don't buy anything more than number 15 size. Ideally you need a smaller size, but a smaller size is not available. Number 15 is what is being available from these companies. So please do not buy anything more than number 15 U files. Okay. Now when you do this ultrasonic activation, it produces cavitation and aqueous streaming, which you all had learned in your theory, which I'm not going to explain now, but I can show you a video of it. This is a routine root canal which I'm doing. You can see the formation of bubbles, the disruption of bubbles, and you can also see the vortex-like movement of the fluid. So this is what happens when you do irrigant activation with ultrasonic tip. Moving on to ultrasonic irrigation, there is something called continuous ultrasonic irrigation. What do you mean by that? It simply means that, see here what we do in passive ultrasonic irrigation is you put irrigant and then you activate. Okay. In continuous ultrasonic irrigation, there will be some pump that can continuously give irrigant into the pulp chamber. At the same time the tip is activating, so that gives better result. And according to my knowledge, there are 3 systems in the market which gives that. One is the Pro Ultra Piezo Flow from Densefly. Second is the Stream Clean from Vista Dental. And there is also one more tip from the satellite, which is the IrriSafe tip, which I am using in my clinic. The only problem with these tips are, see, the solution will be coming out through this nozzle, and in IrriSafe it have an inbuilt port here, and solution will be touching here first. And the problem which I faced in my clinic is there is a lot of irrigant spatter, and especially this spatter, we don't want it with hypo, because this spatter can go into patient's eye and it also can contaminate the operatory. So even though it looks promising in theory, I'm not a big fan of this continuous ultrasonic irrigation. Okay, so the next question that we need to address is at what level the PUI tip should be placed. It's a very important question. Okay, you should not just at what level. I mean, from working length, it should be kept 1 mm, 2 mm, 3 mm, or you can keep it at the orifice. So let's see the evidence. So what evidence suggests is that PUI could remove debris, dentin debris up to 3 mm in front of the file tip. What do you mean by that? From their study, we can conclude that you can place the ultrasonic tip, activation tip, maybe 1, 2 or 3 mm short of the working length. This will be effectively removing all the debris. What about the curved canals? That question also have to be addressed, because majority of the canals that we do in our clinic is not straight. Okay, so here comes the answer, published in 2010 Journal of Endodontics, a beautiful article from Germany. What they found is PUI will not be efficient beyond 3 mm from the curvature. So what they had done is, what we generally do is, the ultrasonic tip should not be pushed below the curvature. It should be activated at the level of curvature. And when you do that, according to their research, they found that the cleaning efficiency will be very good from 3 mm from the curvature. Now the question is, if there is more than 3 mm, imagine the curvature is starting around 10 mm from the working length. So in that case, almost 7 mm will be not cleaned. So many researchers and clinicians used to find some solution for it, and few had found it pre-bending of U files. You can pre-bend the U files just the way we bend the hand files, pre-curve it, and you force it into the working length, maybe 2 to 3 mm short, and activate. So that's a good way to activate, but there are a lot of problems with that. So when you do such sort of activation, effectively you are damping the ultrasonic vibration, because the moment the ultrasonic come in contact with the canal wall, it will have a damping effect. So it doesn't work well, so the agitation energy is decreased. The second is, there is high risk of separation. These are very small fragile ultrasonic tips, so there is chance of separation. Third, there is a chance of ledging, because the tip will be vibrating more and there is a chance of ledging at that point. And finally, there is a potential chance of having ultrasonic irrigation with instrumentation. I hope you remember UI. We don't want this instrumentation, because activation is to remove the smear layer, and when you use with instrumentation, you are actually producing the smear layer. Moving on, and this article had done a wonderful job. What they had done is, it's in press in Australian Endodontic Journal. They had compared the efficacy of PUI, sonic activation with eddy, I'll be speaking about eddy later, and endoactivator on smear layer removal on curved canals. So the finding is, no activation technique was able to eliminate debris and smear layer completely from the curved canals. That is challenging, right? So let's compare these strategies with available evidence about these ultrasonic activation. I'll be speaking about PUI. Now, according to this research published in Odontology, they compared PUI with MDA. You know what is MDA? Manual dynamic agitation, which is the simplest way of activation. So what they found is, in terms of penetration ability into dentinal tubules, there is no significant difference between MDA and PUA, which is very surprising for me, because MDA produced only 3 Hertz and PUI produced 40 Hertz. So logically, it's not right, but you have to accept their conclusion. Again, in IEJ 2007, maybe a decade back, a literature review had found that PUI is more effective than syringe irrigation. Obviously, it should be more effective, yeah, right? Because that's from the understanding, logically, PUI should be more efficient than syringe irrigation. A recent systematic review by Prasanna sir and Venkatesh Babu sir, published in Clinical Oral Investigation a couple of years back. This systematic review addresses only microbial reduction in vitro studies, and what they found is PUI brings superior microbial reduction within the root canal system than conventional irrigation. So again, PUI is better than conventional irrigation. Another article published in British Dental Journal 2019, again a systematic review. They assessed periapical healing and root canal disinfection, and their conclusion is there is no evidence of improvement on periapical healing, that is treatment outcome, and bacterial disinfection that supports the use of PUI over the syringe irrigation in clinical practice. Oops. Not audible. Reconnection successful. Okay, now I got a notification that reconnection is successful. I just want to check with all of you whether I'm audible now. Okay, thank you Remya. Thank you Femina, the Rupal, Ismail, Peter, Krishnan, Renu, Ajay. Thank you everyone. Okay, moving on. So when it comes to this systematic review, it is contrary to all the finding. That is, it doesn't make any difference when you do PUI and syringe irrigation in clinical practice. But I'm little skeptical about their results. You know why? Because when I gone through their the chart, they had screened they had taken around 346 articles and finally come up with 338 articles after excluding the duplicates from various databases, from PubMed, Scopus, Cochrane reviews and all those things, and they had assessed only 3 articles. Out of 338, they had taken only 3 articles according to eligibility, and that's what happens with majority of the meta-analysis. The articles that performs according to the inclusion criteria is very less. That's probably the result was inconclusive. Again, an article published last year in Journal of Endodontics 2019, ultrasonic irrigant activation during root canal treatment, a systematic review. They had found that PUI did not improve treatment outcome compared with syringe irrigation. Again, substantiating the previous article. Also, they had stated that it is unclear whether PUI can reduce the microbial load than syringe irrigation, but is effective in removal of pulp tissue remnants. In addition, they say that overall level of available evidence was low, so no strong clinical recommendation could be formulated. What do you mean by that? It simply means that whether you use syringe irrigation or the ultrasonic irrigation activation, it doesn't make any sense, any difference in terms of treatment outcome according to these recent systematic review. This review in JOE says that, and also this review in British Dental Journal says a similar finding, contrary to all the previous finding. Now here comes the control trial, the final word for all outcome studies published in Journal of Endodontics 2013. They had assessed periapical healing with radiograph and CBCT, and what they found is root canal treatment with and without additional ultrasonic activation of irrigant contributed equally to periapical healing. After reading this article, I was telling myself, oh no, why? Because I read a lot about activation with ultrasonic, sonic and MDA, and finally with the control trial they are saying there's no difference. So why should I learn it? Okay, now the problem with this study is that they had done it in straight roots and straight root canals. They had taken very straight roots, very straight root canal, and obviously the syringe irrigation will be better there. So there is a big lacunae in this treatment outcome study according to me. So moving on, the fourth is the plastic finishing files. The advantage of this is it can go beyond the curvature. There are 4 files in the market as of now. Number 1 is the Ton Ultrasonics. Number 2 is the F files. I'm not sure whether this files is available now. Number 3 is the Eddy tips from VDW. It's an innovative sonic tip. And number 4 is the PATS Pro Agitator tips from Dr. Pimprika. That's from India. So these are the 4 plastic tips for activation. And according to me, this will help you to go beyond the curvature. And it doesn't produce ultrasonic instrumentation because it is a non-cutting tip. That's a good point that have to be noted. So let's move on to the evidence of this. In terms of smear layer removal, they found that these F files and PUI performed equally well. So F files having an equal performance ability as PUI. And in terms of tissue dissolution from lateral canal, when they compared PUI, sonic and eddy tips, they find there's not much significant difference between all 3. So these plastic tips are equally good as PUI according to evidence. So here comes the $1,000,000 question. So do we need to activate the irrigant with sonic, MD and PUI? Because all these high-end studies like meta-analysis and the randomized control trial say there is no difference. I'm more of a practical person, a realistic person, so I can say yes, you still have to do the activation because it is well proven that activation will improve the cleaning efficiency. Even though there are a few contrary studies, I still highly recommend to activate the irrigant either with MDA, sonic or PUI. Okay, moving on. Now we have the negative pressure irrigation devices, and the pioneer of that is the EndoVac. It's a very complex system. I just want to briefly describe what is negative pressure irrigation device. When you do syringe irrigation, you create positive pressure because you are pushing the irrigant into the root canal system. So when you are sucking the irrigant from the tip of the root canal system, that's called a negative pressure irrigation system. And this is so complex. It have a micro cannula, it have a macro cannula, and basically this micro cannula over here, where is that micro cannula? Yeah, here. This micro cannula will help you to help this device to suck the needle all the way from the working length. And the biggest advantage is the apical extrusion of the irrigant is very less, and you get good cleanliness because the irrigant, the tip is going all the way to the working length. So let's see from a few studies, again from Prasanna sir, published in JOE 2012. He compared 4 systems, modified EndoVac, wherein he could able to do some warming, and the second is PUI, MDA and syringe irrigation on isthmus debridement. And the result was little surprising for me because there is no statistical difference between all the tested group. Because syringe irrigation, MDA, PUI, EndoVac, everything performed well in terms of debridement from isthmus. And he also concluded that MDA brought about superior cleaning efficiency compared with PUI in the apical 1 to 3 mm. Again, another article published an year back from Prasanna sir in Journal of Odontology. He assessed a smear layer removal ability of needle irrigation, sonic activation, negative pressure, polymer finishing files, and PUI. You want to know the result? The result is the negative pressure performed better. Okay. So here in this study it says that the negative pressure, the endovac is performing better than all these other systems. Now there is a big practical difficulty with endovac. You know what? Because if you want to put the micro cannula all the way to the working length, you have to prepare at least 30 size. So that is, we are more moving towards biomimetic endodontics, and it's very difficult to probably do these type of comparsum devices. Is very difficult to use. You need to have two people to hold the micro cannula and the macro cannula and all those things. So practically endovac is quite difficult to be used. So that's one disadvantage from my side. Moving on, the fifth is laser activated irrigation, and we will call it LAI. Okay. Now what it does is it produces activation of root canal irrigants via laser, and its cleaning efficiency is basically based on cavitation. It produces cavitation just like a PUI, and we can basically classify LAI or laser activated disinfection into two. One is conventional laser activated irrigation. Second is hovering laser activated irrigation. So you may be wondering what are these. So conventional laser activated irrigation is done with the conventional lasers, and which includes the diode and neodymium yak, not the erbium yak laser. But this hovering laser activation irrigation is done exclusively with erbium yak laser. And what do you mean by this hovering laser activation? Hovering laser activation is nothing but you keep the laser tip on the pulp chamber. You won't be putting it inside the root canal. Whereas this conventional laser activation, you need to put the tip inside the canal and activate. And what is promising nowadays is a unique tapered and strip design from the pips. This is called pips. Okay. The pips basically make use of erbium yak laser. It's a hovering type laser activation, as you can see in this video, that you put the hypochlorite inside the chamber and put this tip and just activate it. So it produces photoacoustic shock waves, and you will get a three-dimensional cleaning all the way into the root canal system. Now when you look into evidence, there are many studies from 1996 to 2008 which says that LAI is superior to conventional chemico-mechanical method. But in this study published in JOE 2018, they assessed the isthmus cleanliness in terms of debris removal compared PUI and LAI, and they found similar effect contrary to the previous study. In addition, O. Peters had assessed the removal of biofilm, and he found that LAI is more effective than PUI. Again, Prasanna sir had published an article in IEJ 2015, compared PUI with LAI on efficacy reduction, and he also found LAI is more effective than PUI. Again, another article which assessed the removal of biofilm. They had assessed all these irrigation regimes: saline, hypochlorite 2 concentration, then erbium chromium yak laser, then saline with LAI, and sodium hypochlorite 0.5% with LAI, and all those things. And what they found is that NaOCl 0.5 plus LAI. LAI is erbium yak, is a overing lace which you make use of the PIPS technology, will give a better results. Again, moving on, Article published this year in 2020, again with biofuel removal. They state that LAI is more effective than PUI. Another article which assessed the penetration depth of irrigant into dentinal tubules, they had compared MDA, PUI, sonic, PIPS and sweep. Sweeps is also a laser activated disinfection. It gives different energy, that's the only difference. It is not hit the market, it is an experimental setup, and in this research also they found that PIPS is much superior than any other technique that is being followed. That is, it is much superior to sonic, PUI, MDA and sweep. Now comes the randomized control trial. Like everything have a sad story. When it comes to post-operative pain, in randomized control trial, this article found that there is no difference between PUI and conventional irrigation. So that's only with the post-operative pain. Okay, probably something related to treatment outcome. You can indirectly convey in that way. So to summarize on laser irrigation, it looks very promising. Okay, the only issue is the cost. The PIPs will be costing maybe more than 20-25 lakhs. I don't know how many of us can afford that. Okay, moving on, the sixth in activation is a recent, not recent, maybe 5-6 years back, is being introduced, is a multi-sonic ultrasonic cleaning system called Gentle Wave. Now what this device does is it delivers a broad range of sound waves. Okay, it produces ultrasonic sounds, like it pops out sounds from this small area with continuous irrigation with built-in suction. So from here sound waves will be coming, from here the irrigation will be coming into the chamber, and there will be a suction that will be attached to the top of the tooth. So I don't know the practical aspect of it, but looks promising, and it produces hydrodynamic cavitation cloud just like this. This is a schematic diagram which I had taken it from the manufacturer's website. You can see the tip will be there. It gives continuous irrigation and it gives that ultrasonic sound waves, and you can see the systematically everything looks fine. The inorganic debris, organic debris are all being pushed out, and you can see perfect dentinal tubules devoid of bacteria, smear layer and everything. So this also looks very promising, like the LAI according to me. Again, this system also may cost you more than 30 lakhs, so the affordability is a factor. So few evidence about Gentle Wave. According to this study published a couple of years back, they found that the teeth with necrotic pulp and large periapical lesion, there is high healing rate at 1 year re-evaluation with Gentle Wave. So this looks very promising. Moving on is the seventh is the antibiotic based irrigating solutions. So there are many researchers and clinicians which follow with antibiotics inside the root canal system. They use antibiotics for intracanal medicament, and they use antibiotics as an irrigant. So the most commonly used antibiotic is tetracycline. You can use 50 or 100 milligram per ml, and like chlorhexidine, this tetracycline also have substantivity, and it will stay for 12 weeks. Other antibiotic solutions in the market are the BioPure MTAD or MTAD, the TetraClean. These are the two with the tetracycline, not tetracycline, it's a variant doxycycline. So these are the irrigants in the market. I'm not sure about the availability of these irrigants now, but I can conclude with this statement. I'm not a big fan of this antibiotic inside the root canal, because higher incidence of tetracycline resistant bacteria can be expected in the future, just like the way the COVID-19 had come. It's a variant of SARS virus So how it happened is we try to resist these viruses. It will take some mutation and come up with new form because it have to survive. So it is not a good habit to resist in the full potential. Antibiotics are not ideally indicated inside the root canal system, and it is been stated by Zender itself long back. Eighth is the silver nanoparticles irrigation with high intensity focused ultrasound. Again, this is a high-end topic. What they say is that there is interaction between positive, all the nanoparticles are positive and the microbes are negative, and the nanoparticles will be attached to the microbes, and the killing will be much easier. The particles that is being tested now in the field of endodontics are chitosan nanoparticles, zinc oxide, and silver nanoparticles. The advantage of these nanoparticles are they are having a broad spectrum antibacterial effect. They are very small size, so it can penetrate into the dentinal tubules. The large surface area to mass ratio, so the efficacy will be good, and it is highly reactive. So these are the advantage of the nanoparticles. The only concern with these nanoparticles, according to me, is that it can form aggregates. So whenever you have smaller things, they always have the tendency to aggregate together, and it will be ineffective to deliver these aggregates to the target. So that's only the concern as of now. And if you ask me who is a pioneer and doing well with nanoparticle disinfection is Dr. Anil Kishan. Yeah, the top one is the first article from his side published in Journal of Endodontics 2008, and the bottom one here is the latest from him, Journal of Endodontics 2019. You can clearly distinguish the design change from the JOE itself. This is an old article they published like this, and the newer one have a different way of design. Okay, moving on. The ninth is the continuous instrumentation and irrigation. This is also very promising, right? Because you have something, some file that can shape. At the same time, some mechanism in which the irrigant is delivered into the root canal system. So you instrument and you irrigate simultaneously. I mean, not simultaneously, continuously. Okay, so this is being done only with one system, and that is called the self-adjusting system. I'm not going into detail again with this file system. Please Google it if you want to learn more about SAF or self-adjusting system. The 10th in irrigant activation is a file that is being introduced a couple of years back, not couple of years back, maybe 4 or 5 years back from FKG. That is called the XP endo finishers and shapers. Okay. Now, when you look into the studies regarding these files, let's first see the biofilm effect from the apical third. They try to compare XP endo finisher, conventional needle irrigation, passive ultrasonic irrigation, and the result is the XP endo finisher is much better in biofilm removal. So that is something promising. Moving on, article published an year back in Clinical Oral Investigation on accumulated hard tissue debris removal, and they found that PUI and the XP endo finisher having equal efficacy in removing hard tissue accumulated debris from oval shaped root canals. Again, the distribution of LNAOCl into the mesial root canal system. You know, mesial root canal system is very complex because there is an isthmus connection between mesiobuccal and mesiolingual will be always there. So they had assessed the penetration ability of hypochlorite into this isthmus area, compared XP endo finisher, normal irrigation, and PUI. And what they found is XP endo finisher presented a better apical cleanliness compared with the other system. Now, XP endo finisher looks promising according to me with the limited available research as far as apical cleaning is concerned. Now there is also one more file which is being tested for apical cleanliness by Prasanna sir, that is the finisher GF brush files from these are actually the Gendel files. The Gendel file, there is finisher files also. So the finishers files can be useful in just like the XP endo finisher to do some apical cleanliness. So according to Prasanna's research, he found that the finisher GF brush improved the debridement of canals, but did not significantly differ from the syringe irrigation. So this file doesn't make much difference with the syringe irrigation, but I would say this XP endo finisher does, yes, it does makes a difference. Okay, let me take a break, maybe 10-15 seconds. Just stay tuned. Okay, it's been 2 hours. Okay. Anyway, thank you for listening to this lecture. Okay. Moving on, a little bit about patency versus no patency. Okay, what do you mean by patency? Patency means, I will explain it in the upcoming slide. So this is a histological image of root apex. You know that this is the major diameter and this is the minor diameter. We call this till the minor diameter, we call it as dentinal canal, and from the minor diameter to the major diameter we call it as the cemental canal, because the cementum will invaginate little into the root canal system, and where it meets, that's basically we call it as the minor diameter. So there is something called cemental canal and dentinal canal. So in root canal treatment, you should have two objectives. One is the mechanical goal and second is the biological goal. So when you instrument with till the working length, you achieve the mechanical goal, but the biological goal is not fully satisfied, because this is also a canal. So we generally put our instrument 0.5 mm short of apex because we don't want the cemental canal to be instrumented. So we create the apical stop here. Okay. So do you think the bacteria will be accumulated here and that will compromise the treatment outcome? That is a possibility. So biological goal is not perfectly achieved unless you clean the cemental canal. So here is a systematic diagram. You have a periapical lesion there. So this is the infected root canal system all the way, taking into consideration about the cemental canal also. Here is the minor diameter, this is the major diameter. So generally we stop till here. So our instrumentation will be limited till here. We don't consider this cemental canal there because that is what we learnt. Okay, so these cemental walls are untouched and can lead to accumulation of lot of bacteria. And according to Cohen and Burns, 1 millimeter of canal have 80,000 streptococci in an average. So we don't want, in root canal treatment, success, every millimeter matters, to be honest. So let's see the evidence. So this study had assessed the irrigant penetration ability when you do the patency. Now patency means, don't get confused, patency and recapitulation. Recapitulation is an older term wherein you take the smallest file to the working length and do some pecking motion. Whereas patency means you take a number 10K file, purposefully go beyond the working length by maybe 0.5 to 1 mm so that you clean the cemental canal. That is patency. So we don't follow recapitulation anymore, we do a patency file. Obviously I agree the fact that the patency is a controversial topic. There are many people who go against the patency. There is something called vital pulp stumps, keeping the vital pulp stumps and all those things. So it's a little complicated topic, so we will leave that as of now. So according to this study, they found that if you have patency, it allows irrigant to reach the canal apex during PUI. Also, it helps the irrigant penetrate into the apical 2 mm of the complex root canal system. So patency will help in indirectly better cleanliness with PUI. Now, this is a histological study, a beautiful study, because they had taken treatment outcome with histology, which is not possible with humans. So the histology is the ultimate treatment outcome study. And what they had done is they had made it into two groups. So in one group, they had instrumented the entire canal, including the simmental canal. And what they found is that when they improved the simmental canal, the periapical lesion healing improved. That's a beautiful finding. So it substantiates the theory of patency. Now you may be having a query that if you have this patency, that means the canal is open, will there be sodium hypochlorite accident? Because when you do this irrigation 1 mm short of the apex and all those things, there is a possibility that an irrigant can push beyond the foramen. Now, there is no report till now about sodium hypochlorite accident during ultrasonic activation in the literature till now. Okay, I had searched it, it is not there. And this is a systematic review published in 2013. It assessed the factors affecting irrigant extrusion during root canal irrigation. And what they found is there's no evidence of NaOCl accident unless we bind the needle in the canal and forcefully irrigate, which we don't want. So never ever bind the irrigant inside the root canal and irrigate. Always keep it loose. Always do the pecking motion in order to address the shear wall resistance and all those things. So some amount of hypochlorite, if it is pushed beyond the apex, will be neutralized by the tissue. It doesn't make much difference. Now here is an image, a picture which substantiates the importance of patency. This root canal has been done well to the working length. It's not audible, Senthil. Please use the headphone. It's raining here, so I'm not sure about the audio quality. I'm doing my best, okay? So moving on, this is a pre-operative graph. This root canal treatment was done maybe 5 years back. Good post-endodontic restoration. You can see the pins here, and the lesion hadn't healed. Okay, so if you look radiographically, it's perfect. There's no problem. The retreatment is attempted and patency was maintained. Okay, here you can see a little bit of sealer extrusion here also, and follow-up shows healing. So here comes the importance of patency. This is probably because the simmental canal is contaminated with bacteria here. That could be the reason why the lesion was not healing. That could be one reason. Okay. Now, there could be concerns about sealer extrusion when you have patency, just like the hypochlorite extrusion. So this is a beautiful article by Rukuki. He is doing a researcher from Italy with Secura Junior, doing very well in terms of disinfection, histology and all those things. He had done few Facebook live, Facebook post on his research. Beautiful. All of you should watch it. So this is an article from them maybe 4 years back, published in GOE. They assess the fate and influence of apically extruded sealer. These are the tested sealer. And they found that the treatment outcome was not significantly affected by the type of sealer. So even it doesn't matter if you push sealer a little bit more. It may create some post-operative pain depending upon the sealer that you use. But according to this study, they say it's not giving any difference in treatment outcome. But there are certain concerns about patency file. Now, the concerns are as follows: patency file in non-infected root canal, in infected root canal, patency file and postoperative pain, and patency file in treatment outcome. So I would highly recommend to get patency on an infected root canal. It is not that important in non-infected root canal. But in an infected root canal, in my practice, I would highly recommend to get the patency. Patency and postoperative pain, yes, you can expect little postoperative pain according to my practice if you achieve patency, because you can extrude a little bit of hypo and all those sealers, and so you can expect little postoperative pain. Patency file and treatment outcome, there is no clear-cut evidence other than few articles published from Rukuki. It's not well proven, so I'm not quite sure about the treatment outcome, but I believe it will be better in infected root canals. How about cleaning dentinal tubules? I told you that is also a challenge. Bacteria can hide inside the dentinal tubule. Here is a fluid dynamic study. Now what they have found is, inside that, when you do this irrigant activation, the irrigant will be pushed into the dentinal tubules by 2.5 micrometer. Okay, so that is 2.5 micrometer it will be pushed into the dentinal tubule. But the problem is the bacteria can go and hide more deeper, maybe 3 or 4 micrometer. Now how can you improve this penetration ability of hypochlorite into the dentinal tubule? This is a beautiful article published a decade back. It says that if you increase the temperature, I mean warming the hypo, increase the time and concentration, it enhances the penetration of sodium hypochlorite into the dentinal tubules. And another beautiful article in Australian Endodontic Journal, that is in Press, okay, again from Prasanna sir and team, had found that dentinal tubule penetration significantly improved by ultrasonic activation of intracanal heated NaOCl. That means if you heat the NaOCl inside the root canal with the help of system B, or you warm it with ultrasonic activation, it will significantly improve the penetration of hypochlorite into the dentinal tubules. So I hope I had discussed all possible ways. There are many more in irrigant, but these are the things which I would like to emphasize more for all the postgraduates and clinicians around the world. In my own limited knowledge, this is what I understood. So I would like to give 8 points to all of the people who are watching. 8 change in understanding, consideration and recommendations. And number 1 is that this is especially from all the postgraduates who are doing endodontics in India. Now we are not bothered about the cleanliness of primary root canals anymore, okay? So we are not bothered about how good is the cleanliness inside the isthmus, inside the dental tubules, inside lateral canal, or inside apical delta. So none of the competent journals will not accept any studies concerned with ACM in the apical 1/3, middle third, and coronal third, just like the way that we do long back. They only accept studies with the help of either optical coherence tomography, confocal laser scanning microscopy, or micro-CT. These are very expensive. So this is the take-home message from my side. That is point number 1. If you're doing any study regarding irrigant, it should be looking into lateral canal, dentinal tubule, isthmus, or apical delta. You should not look anywhere else. And you should use these methods to assess the biofilm or debris removal or all those things. Debris can be assessed with micro-CT and all those things. This is point number 1. Point number 2 is there is enough evidence now to say that it is proposed first by O. Peters, which says that this gel-like EDTA that we use while doing rotary is not required in rotary endodontics. What we do is, more important is to put some aqueous irrigant inside the chamber and do the rotary endodontics. That is having a better efficacy or longevity to the file compared with the the gel-like lubricant. So this is also, we followed this for a long time, that is that gel-like lubricant, you will take it on your left hand, so you should not do that. Probably you can use it for hand filing, for initial scouting, but when you do rotary endodontics, please make sure that you put irrigant inside the chamber as a reservoir and do the rotary instrumentation, so that it will improve the retention time, it will improve the efficacy, and many more. That is point number 2. Point number 3 is that there is no evidence right now which says that adding surfactants into any sort of irrigants, few people had asked that query, into any sort of irrigant like sodium hypochlorite, EDTA, it doesn't improve anything in terms of chelation and pulp tissue removal. There is enough evidence. The Didius is again a beautiful researcher, along with Matthias Sender had found this. Surfactant do not enhance the ability of NaOCl to dissolve pulp tissue, also the chelator to improve the calcium from dentine. There is another study published recently, 2017, which says that there is no difference in penetration of irrigants with and without surfactants into the dentinotubules, which is the smallest portion where the irrigant should reach. So there's no point in using any sort of surfactant solutions now anymore. That is point number 3. Point number 4, we are all bothered about vapor lock once more. Once upon a time, when I was doing my post-graduation, I was always thinking about this vapor lock. Oh my God, whether it happened, how I had removed it, and all those things. But recent articles had clearly shown that apical vapor lock doesn't seem to be a major problem during instrumentation. So please leave with this vapor lock effect as of now and go ahead with your routine irrigation. Now the 5th point is, I would like to quote this article of mine. I had written it along with my good friend Denzel, and we had formulated few things. So when I was doing my post-graduation, I always used to remember this. Why there is no improvement in treatment outcome. When you look into treatment outcome, what we got in 1970s is the same treatment outcome what we are getting now. There are many factors which influence the treatment outcome. One probable reason is we are doing all challenging cases now. In previously, only the easiest case will be selected for RCT, but since we are taking challenging cases, that's probably why we are getting an equal outcome now. But if you look into this article, we had actually put up all the factors which influence the treatment outcome here. Number 1 is a preoperative pulpal and periapical status. Now this is very important. That means if you have a device which clearly says the preoperative pulpal and periapical status, that is really good, because that is going to influence the treatment outcome of endodontics. But unfortunately, now what's the reality is, for example, if you ask any endodontist who had done their post-graduation in 1970s, you ask those people what are the vitality test method that they used in order to find the pulpal status at that time. That means around 50 years back. They say it is heat test, cold test, and EPT. Now, if you ask the recent postgraduate student right now, if I can ask my postgraduate, Dr. Sibin or Dr. Jijo, about the same question, which vitality test you do, I'm sorry, and I got a phone call, I'm sorry. So which vitality test you do when you want to assess the pulpal status, they also say the same. It is a pulp test, EPT, heat test, and cold test. So there's no improvement, to be honest. From 1970 to 2020, we are still doing the heat test, cold test, and EPT. And you know that these tests only assess the nerve supply. It doesn't assess the blood supply. There are few devices called pulse oximetry and laser Doppler flowmetry, but they are not clinically useful. It is not hit the clinical practice. Now, I always used to wonder that why there is no research happening in this aspect. The probable reason could be, see, imagine I could able to develop a device which clearly say that this can go for vital cell therapy, this can go for root canal treatment. Imagine I have a device and I had given to all of you. You know what will happen? Half of the root canal treatment that we do in our routine practice will be changed to vital pulp therapy. Now what we are doing in reality is, even though from our heart we know that this tooth can be saved with vital pulp therapy, we won't be doing it because we are not sure. Many a time later the patient will come with post-operative pain. So uh, uh, we don't want to take a chance. So what we do is we intentionally kill the pulp. Okay. So if you have that such a device, it will be beautiful. So that half of the root canal treatment that we do worldwide will be reduced, according to me. So this is something that have to be improved. That is diagnosis of pulpal and periapical status, so that the treatment outcome will be improved. Now, other factors which influence the treatment outcome are achieving a root canal anatomy with complex systems. That means if you have complex root canal, outcome will be bad. Third is achieving patency to the canal terminus. The fourth is mid-treatment complications. Fifth is root canals with no voids. And sixth is leakage-free coronal restoration. You can find this article. It's a letter to editor in my ResearchGate profile. You can Google my name and go into ResearchGate profile and you can freely download these articles. Okay, I would highly recommend all of you to go and read this article. I had put all the lacunae in the field of diagnosis in this article. Okay, coming to an article again by Secura Jr. From Brazilian Oral Research, published in 2018. What he had stated is cleaning and disinfection of untouched area. You can see the green color or untouched area will improve the treatment outcome. So other than all the factors, all these 6 factors which I had told, the cleaning of the untouched area will improve the treatment outcome, and you know how to clean it. This can be cleaned only with irrigant. Now the 6th point which I would like to give is, it's a question, to be honest. The question is, if you look and heard my lecture, you including me will understand the fact that, or this question will pop into all of our mind, that why there is insufficient evidence to claim general superiority of any one method over the other. Because some may say MDA's method good, some systematic review will say PUA is better, few say LAI is better, and few say gentle way is better. And there is no conclusive evidence of one method superiority over the other. Why is that? Okay, so the answer is very simple. According to me, these are inconclusive due to major methodological limitation and extensive variability in the protocols employed. All these studies are done in various methodology, the sample size, the statistics, all those things vary. So that is one major reason why we have inconsistent evidence about superiority of one method over the other. And this is being addressed recently by my own senior. We done post-graduation in the same college, Meenakshi Ammal Dental College, Venkatesh Babu sir. He had published, along with few stalwarts of endodontists, addressing this these things, and this is the editorial which becomes the nidus for many protocols. And in this article he had mentioned that Majority of research in endodontology begins and ends with laboratory. If you think it's right, you see the articles published in IEG and JOE, almost 70% are benchtop studies, ex vivo studies. And how many are converted to clinical studies? Randomized control trial. If you look into my presentation, there is hardly any randomized control trials to substantiate ex vivo studies. And this is the most important statement. Those results will never benefit a single patient who is giving endodontic therapy. So unless you convert the ex vivo study into clinical study, this is useless according to me. And that is exactly why Venkatesh Babu sir and team had put up something called PRILE, which is preferred reporting items for laboratory studies in endodontology. This is for laboratory studies, ex vivo studies. He had put forth for animal studies, case reports, and meta-analysis also. So according to me, any article that should be done ex vivo should follow the PRILE protocol from now onwards. So please keep a note on this PRILE protocol, and please do read all these reported articles which is published in IEJ. Another major concern with all this systematic review, I got this from Vastev Ballal sir when we shared the room in ISCD conference Vijayawada. He also shared along with me the fact that the systemic health of the patient is not taken into consideration. You take the example of our coronavirus. It is affecting the patient according to the systemic health. So do you think the root canal treatment outcome will be also be directly depending upon the patient's immunity? And the problem with all these randomized control trial, the immunity of the patient cannot be standardized. And that's why I believe majority of the randomized double-blind control trials also can have a lot of faults because they cannot take into consideration about the immunity of the patient. The seventh factor which I would like to give is, as I told before, I'm a clinician and I'm also an academician. So I read a lot from articles, and also I do practice a lot of root canal treatment. So I really don't understand the difference between clinical significance and statistical significance. The researchers will say about statistical significance, but when it comes to clinical practice, we believed in clinical significance. So there is a big debate till now happening, which is better. Some may be statistically significant, but when it comes to clinically, it doesn't have any significance. So clinical significance differ from statistical significance. So you need to understand that fact. And the eighth is about the future. So according to me, in the future, there should be method to clean the inaccessible areas of root canal system on a biomimetic way, because we are going towards a world of tooth conservation in terms of restorative dentistry and also in endodontics. So I'm not a big fan of enlarging the canal too much, but your disinfection procedure should be capable to disinfect the canal in whatever way you enlarge the canal. So if you have competent techniques or gadgets or method to disinfect the canal, even if you enlarge it less, it's fine, you go ahead. But if you don't have, try to enlarge more. So the future is biomimetic cleaning, I would say. So I can summarize my presentation in this single slide, that is, the coronal portion of the root canal can be cleaned and shaped with burr. The middle portion can be cleaned with files, and apical portion can be cleaned only with irrigants. So I am not undervaluing any of these. Everything have its own advantage or good aspect. The file should be used, irrigant should be used, the burr also should be used. A combination will always work. But what happens is that we are giving more importance to these files. We are not giving importance to irrigants. The point where you improve, we give importance to irrigants, that's the point where you improve in disinfection. So this is picture courtesy to my friend Jaydev. If you look into his Facebook profile, you can see amazing, brilliant observations like this. And I asked once Jay, what extra you are doing compared with other endodontists? And he told me that, sir, I'm not doing anything else other than the routine things that we all follow, and I may spend some time in irrigation. So he gives a lot of time in irrigation. That is why all these three-dimensional fillings are happening. So coming to the last part, that is my own irrigation protocol. Let me take a very small break. I'm sorry that it's going too extensive. Coming to my irrigation protocol, I will be compartmentalizing endodontic irrigation into two. Okay, those are, one is during instrumentation, and I call it as working irrigant. Second is after instrumentation, and we call it as final irrigation protocol. So this is how I compartmentalize irrigation regime. During instrumentation, I follow one irrigation strategy. After irrigation, I follow another, and that irrigation protocol is called final irrigation protocol. Now during instrumentation, I use NaOCl and saline only. I don't use anything else. Okay, primarily saline, NaOCl, and probably to flush out NaOCl mechanically, I use saline with a lot of pressure. And I use 5 ml syringe, 25-inch open-ended needle for saline and hypo when I do instrumentation, because I don't want 30 gauge needle at this point of time, because I want the mechanical effect to happen, because I need to push all the debris and everything from the root canal system. So I don't want any smaller needle, because that will have less flow rate, and when you have less flow rate, you have less mechanical effect. So till I finish the root canal treatment, I'll be using a 5 ml syringe, 25 gauge open-ended needle, and I'll be using NaOCl and saline. And the point I finish the instrumentation and I go into final irrigation protocol, I'll be using a 30 gauge needle. Okay, so my final irrigation protocol is like this. I'll be using 10 ml NaOCl with a speed of 5 ml per minute. That will take 2 minutes. That will be my first wash. The second, I will inject 5 ml EDTA after saline. Okay, you have to irrigate with saline here, and that will take a minute. Then I will go to activation. I will again put saline here and put sodium hypochlorite, fill the chamber and do PUI 30 seconds, 3 cycle. I will repeat 3 times the same thing. Then saline wash, again I'll put EDTA, and again I do PUI 30 seconds, but I'll do only 1 cycle. I don't do 3 cycles like EDTA. And finally I will wash the canal either with chlorhexidine or the saline for 30 seconds before I apply I put the paper point or the absorbent point. And this depends upon the periapical status and sealer. For example, if I'm using a hydraulic sealer, I'll be washing with saline. But if I find a lot of periapical lesion, if I'm working on an infected canal, my final wash will be chlorhexidine, because that have substantivity. If I am working on an immature tooth, again final wash will be chlorhexidine, because the bonding will be better, because I'll be doing intraradicular rehabilitation. So in an average, I will be taking 5 minutes per root canal, and there are people who does more than this. And once you are done the final irrigation protocol, the irrigant also will help you to find communication with the canal after the final irrigation protocol, just like this. You can see when I try to take the syringe out from one canal, you can see the movement from the other canal also. So there is some communication somewhere. That is a conclusion from the video, and that communication could be isthmus, a lateral canal or a pure communication. Okay. Now there is some studies on some researchers, for example, John Stropko always favors this injection of gutta perca into the root canal, and he used to advise that you need to give a final rinse with 95% ethyl alcohol. When you do ethyl alcohol as a final rinse, obviously it will increase the surface tension and it removes the moisture, so the sealer penetration will be improved and obviously the leakage will be decreased. There are also studies which says that when you use sodium hypochlorite, these chloride crystals will be formed inside the dentinal tubules, and these crystals will prevent penetration of sealers. So if you use ethyl alcohol, these chloride crystals also is being removed. So 95% ethyl alcohol as a final rinse is promising, but evidence is lacking on it. So with the current available evidence, practicality and feasibility in combining both, I'm not talking about this gentle wave and all those things because that is not practical. So I'll be talking with practicality and feasibility. With the current available evidence, I can say after access cavity, flush the canal with NaOCl. Between instruments, give 2 to 5 ml of NaOCl per canal, open under needle, 27 gauge and 5 ml 5 cc syringe. And in the best available evidence, you can follow either of these two irrigation protocol. The conventional one, the best is NaOCl saline EDTA, and probably you can add chlorhexidine here depending upon the periapical status, or you can do continuous chelation. Continuous chelation looks promising as of now. So either of these irrigation protocol is what is my advice from the evidence from this point of time. When it comes to syringe irrigation, these are my take-home messages. Use 5 ml syringe, minimum 30 gauge for final irrigation protocol, closed-ended needle, 1 mm short of working length, use pecking motion to address the shear wall. You have to get good flow rate, maybe 0.25 ml per second, because that will take you to the laminar flow, and more volume is a key, 5 to 10 ml per canal. So you need to remember these facts. So to conclude, I can say if you are dealing with a large straight canal, to activate the irrigant, PUI is the best method in terms of practicality and feasibility. But when you are talking about narrow curved canals, PUI, I'm a little skeptical, but I would suggest PIPs, expand of finisher, plastic activation tips, and manual dynamic agitation. So this you can divide according to your economic status. Now if you are a practitioner with a lot of money, I would highly recommend to go for PIPs. Or if you have little bit in a financial setup is little less, you can go for XP end of finisher. But if you are doing a regular practice, you can either take this plastic activation tips, or if you are practicing in a very rural area, you cannot charge more, probably you can go for manual dynamic agitation in narrow curved canal. So I would like to divide my final irrigation activation into large straight canal and narrow curved canal. Large canal with PUI and narrow curved canal, I don't use PUI. Instead I use any of these methods. About intracanal medicament, again it's a very vast topic, and I would say it depends on the type of practice that you do. I generally don't use intracanal medicaments. I don't have intracanal medicament in my office. I rely only on irrigants, but if you are not doing a good practice in terms of rubber dam, isolation, irrigation, the protocol, your skill, everything matters. If you are not competent in all those things, it is better to put intracanal medicament because it will help in reducing the bacterial load to some extent. So this is a micro-CT image of apical delta. These are one of my case which I had done. You can see all the apical delta is being cleaned and filled. You can also see similar observation of mine, a lateral incisor. You can see a lateral canal, sorry, a central incisor. You can see a lateral canal here. You can see a upper molar, a lateral canal towards the palatal aspect. You can see mandibular molar also have some apical delta and lateral canals here. This case I had already shown you. You have a C-shaped canal. You can see towards the apex, the isthmus is being addressed. Also, you can see a complete C-shape. You can see the isthmus is being completely addressed. So, in addition, you can see another type of C-shaped canal wherein I failed to identify this canal, but sealer had penetrated all the way into the canal. It is very difficult to identify because it is originating perpendicular to the primary canal, maybe 3 mm from the orifice. So because of my irrigation regime, I hope the sealer had penetrated a little bit about the GP also, because I'll be doing a 3-dimensional filling. So my workflow is very simple. My workflow is like this: split dam, caries removal, redam, build up depending upon the case, shape. I do a lot of importance to cleaning, 3D filling, post endo, and follow. This is the workflow for me, and I'll Okay, so this is a post-off image. So I would like to have all of you to have a look onto the post-off image. So you can see a lateral canal here. This is because of the irrigation protocol which I had followed, and I always believed in minimal preparation. You can see the apical size here. Also, you have to understand the fact that how good is the root canal treatment. If you do a bad post-endodontic restoration, it will affect the treatment outcome. So fortunately, I'm an restorative dentist and an endodontist, so I can do good restorations also. So this combination always work symbiotically in order to give predictable result. I'm going to show you one more video. It's a little complicated case. You can see large lesion here. Actually the screw post which is being pushed into the furcation. They had put the screw post into furcation, and this patient have a long history of sinusitis also. Dr. George had referred this case to me. Just watch it.
You can be out of your mind that you hold on. There are some ways you can that will take you to let go. I gotta stay away right now. I gotta fly away like a bird. I gotta climb up. I gotta recall. I gotta stand up. You should be there for me. I gotta climb up. I gotta recall. I gotta stand up. I'm sparkling. Tell the world the grace you own, absolution you attain. You can know the choice you take. Look upon the face, rapture. I gotta stay away.
Okay, so this is a post-op radiograph. I hope you had enjoyed the music also. The music was sung by my own brother Tony. Okay, so hopefully I hope all of you had enjoyed the foreground and background. The case is done by me. If you want to hear the music, just rewind once more. So again, look into the post-op radiograph. You can see beautiful obturation. I'm not appreciating my work. I'm just trying to inspire all of you. A lot of lateral canal is being addressed, and we have a follow-up of this case. Beautiful healing was achieved, and Dr. George had, I hope Dr. George had given a crown for this patient. Okay, moving on, the last 3 or 4 slides from my side. I would like to show 5 cases of mine done between 2007 and 2011 when I was a postgraduate student. Case number 1 is a 8 root canal system. You can see 8 orifices published in GOE 2011. Case number 2 is 7 root canal system, again published in GOE 2010. Another case of C-shape root canal, C-shape anatomy on the palatal root, triple OE 2011. Another one is a 7 root canal system on mandibular second molar, published in QI 2014. The 5th one is a lateral incisor with 4 root canal system. Now I would be happy to tell that it's a real honor to get your published cases in the cover image of 2 specialty journals, GOE and IEJ. This is a 7 root canal system, was published in the cover image of GOE 2010 May issue, and the IEJ had taken the 4 canal case as a cover image in April 2012 issue. I would like to all of you to take an attention to the post-op image here. You can see the 8 root canal system here. This is an extreme angulation, and you can see 8 orifices here. But look at the exiting foramen, 1, 2, 3, 4 and 5. So there are 5 exiting foramen and 8 orifices. So 5 orifices and 8 foramens. This is what I got in 2010. Okay. So this article, this was also came in the cover image of GOE in 2011. Now this is a change in vogue or change in trend. So a decade back, when I was doing my post-graduation, we all are really bothered about getting number of orifices. So I was always searching for more orifices inside the pulp chamber floor. Now this is what happened maybe a year back in 2019. A patient came to me, and this is just before obturation. I got 4 canals, palatal, MB1, MB2 and distal buccal. And look at the post-op radiograph. I want all of you to look carefully on the post-op radiograph. Here I got 4 orifice sizes, 1, 2, 3, 4. But look at the exiting foramen. In the mesial root, if you look very carefully, 1, 2, 3, 4, and 5. In the palatal root, you have 1, 2, and 3. So 5 plus 3, 8, and distal 1. So 9 exiting foramens. You can call it as, theoretically, you can call it as a 9 root canal system. So this is a change in vogue, that is change in trend. A decade back, I never used to give more importance to irrigation. I used to give more importance to shaping. But now I give more importance to irrigation. I'm not bothered about the orifices. What I'm really bothered is how much exiting foramen I can obturate, how much anastomosis I can fill, how much lateral canal I can reach. This is my primary goal. So that's a change in trend. I want all of you to have the trend changed now. So you all know that the life and dentistry and endodontics won't be changed after post-COVID. I'm hoping to recover as early as possible. So I want all of you to understand the fact that the irrigation after this lecture post-COVID also should not be the same from your side. I want all of you to improve on your irrigation regime. So as a conclusion, I can say success depends on canal cleanliness and not shaping. So cleaning is more important than shaping. And I would like to acknowledge all my teachers, especially my head of the department, Vail sir. Kopi sir was a true inspiration. Kritika ma'am had helped me a lot. Suma ma'am was my LD guide. Nandini ma'am was also very supportive. Abhi sir, my senior, and many more. The list is endless. I would like to specifically thank all of these people, because what I am today is because of my teacher. I was not like this when I joined my post-graduation. So the proper guidance is what they had given me in all sense. So I would like to acknowledge all of my teachers, and I generally do it after all my presentation. That's it from my side. Thank you. And if you have any queries, you can contact me via this platform. You can either email me at dr@rootcanalpoint.com, or there's a Facebook page called Root Canal Point. Please like that page, and any queries will be addressed from that platform. Okay, so let me see the time. It's 8 o'clock. It's almost 3 hours. I'm very thankful to everyone or patient listening. I hope it is very informative. The irrigant is very extensive, but I've given my best to make all of you understand where irrigation in endodontics stands at this point of time. Okay, I'm not sure whether I can address all of your queries. All your queries you can put up. I'll be addressing soon. Let me take a break and I'll get back with the queries. I'd put the lecture such a way that you have limited queries, because all queries I hope I had addressed. Anything else I missed, please put a note. I got a message from Prasanna sir. He's in Hong Kong now. He's watching my presentation. I'm really honored. Thank you, sir, for all the guidance. Thanks, everyone. Thanks, Ajay, Ramya, Deepthi, Amrita, my dear student Krishna, Danya, Sachin, Ashwati, Srisha, Mahanu, Rupal, Deepak, Madhu sir, Amina, John sir, Anne. Thank you, everyone. Richie, thank you. Sir, your input regarding this use of sodium thiosulfide to neutralize NaOCl after its use, following by the use of, I will address it soon. Okay, yeah, there are a lot of comments coming. I will address it soon, Richie, don't worry. Thanks, Neha. Winnie, hope you're doing good. Thanks, Nasrin, Pavadi, Arun Kumar. Thank you, everyone. And I would like to end this Facebook Live by thanking Dr. Rahul, who had introduced Endo Haveli. He's the one who had invited for me to this talk. It's been shared in all these 3 platforms, Endo Haveli, my own Facebook page, and the IACD page. You can access this. I will not be deleting this. Anyone can free to access at any point of time. So I would like to especially thank Rahul for the invitee. I hope I hadn't disappointed anyone. And that's it. Okay. It's time to stop the live because we have taken too much time. Bye-bye. Good night.